I'm Peter Block at TCT 2019 for ACC.org. We're in San Francisco. It's a beautiful day, and I'm with a very lovely lady, Myra Guerrero from Mayo. Myra, you have been interested in mitral valve-in-valve. A funny sort of sub story, but nonetheless, there's a lot of mitral valves out there placed surgically that have to be redone. So tell me a little bit about what we know about surgical outcomes. This has nothing to do with your trial, but just as background, very quickly, and then we'll get to the trial.
So the operative mortality of repeat mitral surgery is high. It's in the double digits, proved by multiple studies, including a recent review of more than 1,000 patients from the STS database, where the 30-day mortality was 11.1%. So double digits is high.
So double-digit mortality for surgical redos.
For redo.
Period. That's a good background against which we think about transcatheter work. So tell me now about your trial, the mitral valve-in-valve, and then we'll get the TVT registry business and how that all worked.
Thank you. So the mitral trial, where we looked at, which is the only prospective trial of mitral valve-in-valve in high-risk patient population, what we did in that trial was to evaluate the safety and efficacy of the SAPIEN 3 valve with transeptal access. We knew from prior experience, in the early experience of mitral valve-in-valve, from the VIVID registry and prior in TVT, when they were using first and second generation devices and mostly transapical access, the 30-day mortality was 8% roughly. So a little bit less than surgical, but still not great. So I thought, well, let's look at what happens if we use a third generation device in transeptal only. So that's what we did in mitral trial. And to summarize it, the STS score in that patient population was 10.2%. The 30-day mortality was 3.3%. When the STS score was 10.
So a major reduction, at least against STS mortality.
Correct.
Right?
And it was not a cardiac death. It was non-cardiac. The patient choked taking pills. So the cardiovascular mortality was 0. And at 1 year, I just presented that at EuroPCR this year, at 1 year, it did not change. So no other patient died. It was 3.3 at 1 year.
You know, that's amazing. It's hard to believe that nobody died even after 1 month to 1 year, but they didn't. But there were relatively few patients.
Correct. Only 30 patients,
Yep.
highly selected group, and a highly experienced operator. So the question, that's the reason why we wanted to do this analysis. The question is, okay, well, those are trial patients, but what does that mean for real world experience?
So the TVT registry is where you went.
Exactly. That's where we went. And we saw that now transeptal is the preferred method of delivery in this type of cases. At the beginning, it was less than 20% transeptal, but now it's more than 80%. So we looked at all the procedures, transcatheter mitral valve replacements done with SAPIEN 3 since June of 2015 until like last month. There were more than 1,500 mitral valve-in-valves, about 1,300 done with transeptal access versus like 200 done with transapical. And the key points were technical success was very high in both arms, 97% for transeptal, 95% for transapical. And our primary effectiveness endpoint was all-cause mortality at 1 year.
So let me just interrupt, because remember, this is valve-in-valve, not valve-in-ring or valve-in-mac.
Correct. Purely valve-in-valve.
Important to point out.
Thank you for asking.
Because that's an important landing zone.
Correct.
Okay.
Correct. So thank you for asking. So there were 2,100 total cases, but some were MAC, so some were valve-in-ring, so we excluded those. This is purely mitral valve-in-valve.
And what'd you find?
So we found that at 1 year, there was lower all-cause mortality in the group of patients who were treated with transeptal access, like 15.7% versus 21.6% in the transapical.
Transapical has never been a great operation, has it, to
Correct,
be honest?
But all prior registries have not been able to demonstrate a statistically significant difference in outcomes. And I think it was because of the low or small sample size. So we finally were able to have enough statistical power to show with a p-value of 0.03 that the all-cause mortality is better when you use a transeptal access, and it was an independent predictor of mortality.
But it's still double digits, isn't it?
Actually, that's a 1 year. No, at 30 days, thank you for asking, no, at 30 days, the 30-day mortality for transeptal was 5%.
Okay.
When the ST score of that patient population was 11.
Right.
So the observed to expected mortality ratio was 0.45. And compared with the surgical literature of also being 11%, and the 30-day percent with transeptal is 5, So that's a big improvement in mortality.
That is improvement.
So the other one
Okay.
was at 1 year. The 15.7 is at 1 year.
Okay, so 15.7% is 1
It's at
year.
1 year.
So there's a fair number that do not do well between their original operation or
correct.
their redo and their 1
Yes,
year.
but it's high-risk patient population.
Of course.
There's the score of 11, just like TAVR. In the TAVR population, on the TCT registry, also mortality is more than 20% at 1 year.
Mitral redos are never good, are they? In any case, it's wonderful data, and we finally know that transeptal is the way to go for a valve-in-valve.
Yes.
And important to know that we're still dealing with double digits, but, you know, manageable double digits at 1 year, and that's very good. 30 days is awesome, isn't it?
It's great, yes.
Single numbers. So for those of you who have patients who have old mitral valves that are deteriorating, we have a transcatheter way of doing it. It's now the right way to go. Is that a fair thing to say,
It is the
Myra?
right way to go.
I think that's important, and the 30-day mortality is low, and 1 year mortality is reasonable. They usually die of other things and complications, but mitral patients are always tough. Thank you, Myra.
Thank you.